Our next speaker is Dr. Nabankur Ghosh, who will speak upon prone PCNL in difficult anatomy.
So, good evening, my seniors, my colleagues, and my juniors. I sincerely thank Bengal Society for giving me the opportunity to share my brief experience on doing PCNL in difficult renal anatomy. I have intentionally dropped the word prone because the anatomy is, in whatever way you do PCNL, supine, prone, or lateral, the anatomy remains the same, and the difficulty due to the aberrant anatomy also remains same. Let's have a quick recapitulation from our embryology books. The kidneys, they originate in the sacral position, moves to the lumbar position between 6 to 9 weeks, and as it moves, it also rotates medially, so that the hilum, which was initially facing anteriorly, it now becomes medial. And as it moves upward, it receives a series of lateral sprouts from the dorsal aorta, and the final pair remains as the present renal arteries. The axis of the kidney, which passes through the poles, around which the rotation of the kidney occurs, makes an angle about 30 degrees with the vertical plane. World over, the incidence of anomalous kidney ranges from 3 to 11%, and there is increased incidence of stone disease, mainly due to the impaired urinary drainage, due to the abnormal anatomy, such as PUJ or high insertion of the ureter. PCNL is now considered as the gold standard surgery, particularly for large and complex stones in kidney and upper ureter. But PCNL in such anomalous kidneys offers some challenges to the endocrinologists due to the abnormal orientation and anatomy of the calyces, and due to the increased risk of damaging the surrounding viscera or renal aberrant vessels during surgery. Various classification systems of anomalous kidneys are there in literature, but this is a very basic practical classification. Rotational anomalies of the kidney, the malorate kidneys, kidney with duplex system, fusion anomalies of the kidney, of which two are particularly important, horseshoe kidney and crossed fused ectopic kidney, and ectopic kidney, of which pelvic ectopic kidney needs a separate mention. Once again, in embryology books, various rotational anomalies of the kidney have been described, but the most common is a simple malrotation, which is actually quite common than expected. And this is more so for those who used to do PCNL based on an X-ray or an ultrasound, which comes as a on-table surprise during RGP. Therefore, to avoid such situations, good quality preoperative imaging in the form of IVU or a CT radiography is required. A good technique in such cases is going through the roof. I will explain what I mean by going through the roof. Now just imagine kidney as a room. So you can enter the room through the doors or the windows in the walls, or you can enter through the roof. Now in malorate kidneys, the middle calyces, they are either two medially rotated or two laterally rotated, but the roof, that is the superior calyx, almost remains constant. So if we go through the roof, in such situation, we can actually reach most part of the kidney except a few middle calyx. A duplex kidney has two ureters coming from single kidney, and these two ureters can drain independently in the bladder, or they may connect to form a single ureter to drain into the bladder. These are the two extreme forms of duplicity. On the left hand side, there is complete duplication with two separate ureters draining independently into the bladder. On the right hand side, there is merely a bifid pelvis, which is draining into the common ureter, draining into the bladder. These are the two examples of cases where PCNL was done in duplex kidney. In the first case, the stone was located in the superior calyx of the superior moiety of the left side. On case 2, the stone was situated in a middle calyx of the lower moiety. In both cases, technically it's a little difficult because in case 1, the superior moiety of the superior calyx was very high, and on case 2, it was very medial. It is very important for duplex kidneys to accurately localize the stone before doing RGP. You must know where the stone is, in which kidney or which moiety, and in which calyx. Because the two systems are completely different. If the stone is located in the superior calyx, you cannot expect to reach by puncturing and entering into the lower moiety. Particularly for complete duplication, always look for the ureteric orifices, because the ureteric orifices may be ectopic. I had a case where I found the ureteric orifice is actually, in female patient, is actually in the vagina. Always place the ureteric catheter in the stone-bearing moiety. I've explained this by a simple line diagram on the right-hand side. Suppose the stone is situated in the lower calyx of the lower moiety. Now, if you try to pass the ureteric catheter blindly, it will invariably go into the upper moiety, because the ureter of the upper moiety and the common ureter is in the same line. So, sometimes you may need a ureteroscope to direct the guide wire into the lower moiety, and over the guide wire you have to pass the ureteric catheter. Otherwise, what will happen if you inject a contrast in such a situation? The upper moiety will get opacified, and very low or almost no dark contrast will go into the lower moiety. Now, suppose if you have this was detected when the patient is already made prone. Now, in case of incomplete duplication, you still have a chance of rescue, particularly in case of incomplete duplication, before turning the patient again into supine and lithotomy, and then removing and again placing the ureteric catheter. You just pull the ureteric catheter from below, so that the tip of the ureteric catheter lies just below the bifurcation of the two ureters. And then inject an extra volume of contrast, so that the contrast will now flow in both systems, and both systems will get opacified. Again, various fusion anomalies of the kidney has been described in literature, but the most common is a horseshoe kidney, which occurs in roughly 1 in 600 births. Here, there is fusion of the both kidneys at the lower pole, leading to failure to ascend, because these must get arrested at the origin of the inferior mesenteric artery. There is incomplete rotation of the both kidneys, and there is high insertion and lateralization of the ureter, leading to impaired drainage, and that is why there is high incidence of kidney stones among adults in HSK. This was a case where the stone was located in the left moiety, in the middle calyx. But when I did the RGP, interestingly, there was no dye passing into that calyx. The calyx was almost full with the stone. So I did a stone-guided puncture and removed the stone. This is another case where the stone was located. This is comparatively easier because the stone is located in the pelvis of the kidney. So I went through a middle calyx and cleared the stone. Now, PCNL in HSK is surprisingly more easier compared to normal kidney because of two reasons. Number one, the kidneys are usually located below. So if you approach the upper calyx, you can easily enter into the kidney without the increasing risk of chest complications like we used to get apprehended in normal patients. And second cause is that the kidneys are used in HSK are usually to some extent the pelvic system is dilated. All the calyxes you find dilated, infundibulous or wide. So if you go through the upper calyx in case of HSK, you can reach almost all part of the kidney and clear the stones from any part of the kidney. The second most frequently observed congenital malformation is the crossed fused renal ectopia. Here, the ectopic kidney crosses the midline and merges with the orthotopic kidney of the other side. The left to right crossover is most common. Interestingly, that both ureters are usually, ureter orifices are remain same. That means the ureter of the lower moiety has to cross the midline to reach the ureteric orifice of the other side. 6 primary categories of crossed renal ectopia has been described. In my entire career, I have actually encountered 2 such cases of this crossed renal ectopia where PCNL has to be done. This was a case which I have done about 2 years ago. The stone was located in the superior calyx of the lower moiety. So this is technically to some extent difficult because stone located in the upper moiety is relatively easier. The lower moiety kidney is not only below, but also it is very deep. And those who have attended Parcon this year, I think they have seen Dr. S.K. Pal was demonstrating a PCNL in such cases where the almost entire amplux sheath get inserted into the body. So always be prepared in such cases. Be prepared with an extra long amplux sheath because kidneys they are not only low but also very deep. Fortunately, I find a window through the lateral surface of the lower moiety, which actually on body surface is very medial, almost close to the lateral border of the spine. This was the RGP. I placed the ureteric catheter in the right ureter also to opacify both the systems simultaneously. And I made a puncture through the upper calyx and entered in the system and cleared the stone. And this was the case which I have done just a week ago. This is relatively easy because the stone is situated in the upper moiety, upper calyx of the upper moiety. So I punctured through the upper moiety, upper calyx. I was planning for a mini PCNL like the last case, but my mini PCNL scope was not working. That's why I have to do a standard PCNL with 20 French amplux. Pelvic ectopic kidneys are susceptible to calculi and hydronephrosis due to impaired drainage. And this is due to the anterior position of the renal pelvis, the malrotation of the kidney, the high insertion of the ureter, and anomalous renal vasculature. Now, the problems of PCNL in pelvic kidney stones is that kidney is not only low down, but it is also rotated anteriorly. Posteriorly, it is guarded by sacrum, so no way we can go from behind. Anteriorly, there is a peritoneal sac which contains gut loop below the abdominal wall. So during PCNL, a laparoscopic assistance is essential to avoid injury to the bowel and anomalous renal vasculature. This was a case which was done at Calcutta National Medical College, where SAR was there about 10 years ago. The stone was located in the ectopic left kidney in the pelvis. So 2 surgical teams with separate innovation camera and monitor. Retrograde ureteric catheterization was done. Patient was placed supine. 10 millimeter umbilical port was done, and 2 5 millimeter ports was done in the left, one in the left midclavicular line, one in the left iliac fossa. This is a small video to demonstrate the procedure. This was the ectopic kidney. The peritoneum overlying it was removed. It was deperitonized to confirm our diagnosis and also that to avoid any important structure. Then puncture was made under CM guidance, and it was monitored by a second laparoscopy surgeon. After successful puncture, it was dilated. Then the tract was dilated and the amplux sheath was used. At that time, we used to use comparatively larger sheaths, 28 French, I think, in this case. We have done a similar case at Calcutta Medical College also, where Birasar was there. The point I want to make in this case, that during the dilatation, your guide wire should be absolutely straight. Because in normal PCNL, we have a supporting structure. Outside the kidney, we have a good supporting structure with muscle, retroperitoneal fat, and other tissues, subcutaneous tissue. But in these cases, a significant portion of the tract remains virtually suspended in air. There is no supporting tissue at all. So if your guide wire gets bent, you are gone. So you always try to dilate without bending the guide wire. So normally we used to do single step dilation, but in these particular cases, I think serial dilatation is more fruitful. Thank you.
Thank you, Nabankur, for your excellent presentations. It reminded me of the last cases of during my tenure in National Medical College, and I feel very happy to be part of that OT during that time.